Welcome, everyone. Thank you for joining us today in our Meet with Expert in Regional Anesthesia series global webinar. My name is Nick. I'm the host today. It's my privilege to have two experts today, our old friend, Professor Paul Kessler, and our new friend, Dr. Morné Wolmarans. So at first, I would like to introduce our expert. Professor Paul Kessler is board certified in anesthesiology, critical care medicine, pain therapy, and emergency medicine, and was awarded professorship in anesthesia in 1998. He received his specialty training in anesthesiology at the Johann Wolfgang Goethe University in Frankfurt, Germany. From 2003 to January 2020, he was chair of the Department of Anesthesiology, Intensive Care Medicine, and Pain Medicine of the Orthopedics University Clinic in Frankfurt, Germany. Since February 2020, Professor Kessler is vice chairman of the Clinic of Anesthesiology, Intensive Care Medicine, and Pain Therapy of the University Hospital in Frankfurt. His clinical expertise focuses on regional anesthesia. Professor Kessler has co-authored over 100 peer-reviewed papers, reviewed articles, case reports, and book chapters. Paul Kessler is a member of many national and international societies of anesthesia. From 2009 to 2014, he was chairman of the German Task Force of Regional Anesthesia. From 2009 to 2013, he was board member of the ASRA, and from 2014 to 2018, he was the German zone representative in the ASRA Council. He's currently the chair of the ASRA Cadaver workshops. And also it's my privilege to introduce our new friend, Dr. Morné Wolmarans. He has been the consultant anesthesiologist at the Norfolk and the Norwich University Hospital in the United Kingdom for 17 years, starting his medical practice in Cape Town, then moved to London and finished specializing in anesthesia and intensive care medicine in Cambridge. Developed special interest in ultrasound regional anesthesia in 2000. Regularly lectures, organized workshops, and have established ultrasound courses nationally and internationally. Actively involved with RA UK board for the last 10 years. He's also the immediate past president for Regional Anesthesia, United Kingdom, also known as the RA UK. An ASRA board member, vice chairman of EDRA board, an examiner for the EDRA diploma and the external examiner for University of East Anglia Master Program in Regional Anesthesia. His special interests are education in ultrasound regional anesthesia, RA non-technical skills, vascular anesthesia, and also, of course, golf and fine wine. The first topic is presented by Dr. Wolmarans.
Excellent. So, good. Nick, can you just say a thumbs up if the slides are good?
Yes, it's very clear.
Excellent. Well, we'll start. I was asked, thank you very much for inviting me and for Wisonic to oblige me talking about one of my favorite subjects, which is regional anesthesia, especially for knees. We all know that knee replacements are obviously slightly more painful than hip replacement. So I have a few disclosures to make. And from that point of view, I am on the advisory board for Synthetica, and I've had some equipment from Braun. Now, why is this a particular problem? We know that people that are not used to opioids, opioid naive, if they have opioids for more than 3 months, that 6% of them can become addicted to narcotics. So this is quite a big problem, especially in America. And we know that acute pain precedes chronic pain, and this can happen after total knee arthroplasty. If you look there at the second area where we're looking at hips and knee replacement, 8% of patients having these operations have new persistent opioid use. And if they then continue longer than 3 months, 6% of them can become addicted to opioids. So I feel this is an area that we need to do something as anesthesiologists. We know that post-operative pain is there, and in chronic knee pain can occur anywhere from 10 to 35%. And this is quite a severe impact on pain, and this is one of the major impacts of patient dissatisfaction, one of the main reasons why patients complain after knee surgery. So if there's something that we as anesthetists can do to get this under control and help the patient through this particular procedure, then I think we are obliged to do so. I won't spend too much time on the traditional techniques, and these are obviously a combination of lots of different things. When I started with anesthesia, every knee replacement had an epidural or combined spinal epidural, and then an epidural would be run for 3-4 days, sometimes 5 days post-operatively. We then slowly but surely moved to lumbar plexus blocks or psoas compartment blocks, which are very, very similar. And then you would do a femoral sciatic nerve block and carry on from there. There was still, mobility was still an issue. And we thought, well, actually, we'll move to femoral catheters. And then we'll slowly but surely just run very low concentrations on a femoral catheter and see if we can increase the mobilization from that point of view. But these traditional techniques have had problems, and the major problem is, well, obviously the patient has a catheter as well, but also mobilization and fall risks. Even though Brian Ilfield in the bottom study there, you'll see, has done major work and mentioned that actually this quadriceps weakness that we get from nerve blocks is not all just due to the nerve block itself. Remember, when you have knee surgery, that you have about 40% quadriceps weakness just from the surgery itself. So people with or without regional anesthesia techniques will have quadriceps weakness just from the surgery. So even though these fall risks were often blamed on the regional anesthesia, that is really not the case. And we need to see if we can improve things further on. We then also want to optimize the patient, because we realized the sooner we can get the patient back to the fastest functional recovery and have fewer side effects, they enjoy being up and about, eating and drinking, mobilizing and sleeping well. So that's what we call the dreams, what expectations that we would like to expect from our regional anesthesia. So if we can achieve that with the help of regional anesthesia, that will be absolutely fantastic. But we must remember, what is the patient's expectations? They don't want to enter the Olympic Games anymore. Some of them just actually want a good night's sleep without pain. Some just want to be able to walk their dog and have a little bit of activity. Other people have different expectations. So it is important that we understand our patients and understand the patient expectation. There must be a pathway in place when we actually deal with total knee arthroplasties. And this involves a preoperative area, an intraoperative, where hopefully we'll have more impact, and then post-operative as well. And you'll notice that under the preoperative area, there are things like education, nutrition, optimizing, actually getting people fit for surgery. It's something that we often lack, especially in the UK, where the BMI of some patients can be really high. And it's very difficult to tell patients you can't have your surgery until you've lost a little bit of weight, or maybe a lot of weight. But we all know, those patients with high BMIs are sometimes struggling with painful hips and knees, and they blame the knee for not exercising, and there's a vicious circle there. Things like pre-warming, as I said, and also preemptive analgesia. Intraoperatively, we're looking at regional anesthesia, and I'm talking about not just about spinals and combined spinal epidurals, but also the peripheral nerve blocks and local infiltration, which I'll mention more. We want to be normothermic, normovolemic, use cell saver. We're not giving bloods much anymore, and get your antibiotic prophylaxis in nice and early. Afterwards, we do want a multimodal opioid-sparing analgesia regime. And I think that's the important bit. A lot of people are going on about non-opioid-based anesthesia. I think that's rather difficult and very ambitious, but I think a opioid-sparing analgesia is certainly part of what we practice and what I think regional anesthesia can offer us. And because we are reducing the opioids, we'll have less postoperative nausea and vomiting, hopefully earlier oral intake, earlier mobilization, and then we can get to those dreams that we want to fulfill. Now, this Icarus study, now if you see Stavros Methsudis, if you see his name on almost any study, it's definitely worthwhile reading. He does big numbers, big meta-analysis of all sorts of things, and what he publishes is usually very good quality data. So look out for that name, and I think he will be at the ESRA meeting next year in Greece. But anyway, the point is that regional anesthesia is an essential part of the recovery of this. A friend of mine, Ed Mariano, mentioned this bit. It's almost like the cycling team. A few years ago, the British cycling team was extremely good at the Olympics because they used this bit of marginal gains. So just small things making differences and improving every small aspect. And because you are improving small aspects, you actually gain a large enhancement in your practice. So don't just stick to one way. There are other ways of doing things. And don't just stick to what you've done for the last 20 years. Look at other options. And that might even be including educating your surgeon, not just your surgeon, but also your patient. We've noticed from this particular study, just on the patient being involved and engaged in the postoperative pain management, knowing what to expect, having the right expectations, that their opioid consumption can drop from 71 milligrams down to 30 something. But enhanced recovery is definitely part of total knee replacements, but it's not just one clinical pathway. It's not just one multimodal analgesic. It's not the same recipe. It's not us being a bit more sympathetic, or it's not just us applying regional anesthesia. Regional anesthesia technique forms a part of this enhanced recovery program. And you will notice that you have two patients and their histories are completely different. And you cannot treat them exactly the same, and you cannot have the same expectations, because I'm sure in China, people are much thinner, much more physical and fit compared to our British and American counterparts, where the patient selection is really important when we come to selecting not just the type of regional anesthesia, but also the expectations of that particular surgery. And I just want to emphasize this, that multimodal analgesia is just part of enhanced recovery. And a few other things is that you get non-pharmacological things as well, like compressions, like cryotherapy, acupuncture, etc. And they are variable. It depends on the setup that you have in your particular hospital. Non-steroidals, gabapentinoids, those things, and then local and regional anesthesia, which is obviously what I will concentrate on for most of the rest of the particular lecture. The non-pharmacological ones is the cognitive behavioral therapy, the education, which I've mentioned already, and then also training or educating the patient on this transmission of pain and the sources of pain and how they can work around that, and having virtual reality distraction during some of the actual procedures. I don't think it'll work in the long term, but virtual reality during the actual placement of regional techniques, that seems to work well, and you don't need to use sedation. I guess from a regional anesthesia point of view, everything comes down to anatomy. So let us just look at the knee innovation. I just want to emphasize that a lot of my residents just look at skin innovation and they think, well, actually that's all that matters, but that's not true. You have osteotomal, or some people call it sclerotomal innovation. And when you are doing orthopedic surgery, it is extremely important that you know about the innovations of these things. And you'll notice on the right-hand side at the back of the knee that S1, S2 might have some innovation to the back of the knee of the bone. If we look at the most common approach for a knee replacement, it's an anterior medial approach. And there we will encounter the infrapatellar branch of the saphenous nerve. the medial vastus muscle nerve, and the anterior branch of the medial cutaneous nerve. So the innervation definitely has a femoral component, a sciatic component, and an obturator component. Or as I would like to classify, just an anterior aspect and a posterior aspect. And I will go through some of these things, how we have different options for anterior and posterior aspect. But when you're looking at knee analgesia and regional anesthesia techniques, you must consider having a posterior and an anterior technique. One is no good without the other. Now, Thomas Benson did this fantastic article, and I think he won an Ezra Prize for this particular article on optimal analgesic block for total knee replacements. Very good anatomy pictures in there. And then also Philip Peng, his group has been meticulously looking at the innervation of different joints, the shoulder joint, hip joint, and the knee joint. And he has come up with these fantastic diagrams which shows you the innervation of the individual nerves and also the variations of where they might be. So this is, again, a fantastic article and resource for us to help us guide our analgesia. But now that we understand the innervation of the knee capsule a little bit better, we need to know what to do. So during the actual procedure, a lot of us are still using neuraxial blocks. And this study from the Toronto group looked at more than 10,000 patients. 8,500 had neuraxial blocks or spinals, and they had showed a lower 30-day mortality in the spinal group and shorter hospital stay. In my hospital, unless there is a particular contraindication or patient refusal of spinal anesthesia, all our hip and knee patients are being done under spinal anesthesia with then a very light general anesthetic or sedation if required. If we look at the impact of peripheral nerve blocks, this is again a study from Stavros Mathoudis, and then also a smaller study on the bottom right-hand side. You will notice that there are lower risk of complications, transfusions are less, earlier discharge, and these are big numbers, 382,000. And then there are various aspects of regional anesthesia in the enhanced recovery program that helps us. So we know that when the patients wake up, their maximal pain scores are lower if you use regional anesthesia. We know the opioid consumption is less. We can mobilize quicker depending on what type of regional anesthetic you use, because obviously if you're using a very dense epidural, that's not going to work. And then also hyperalgesia or persistent pain hopefully can be reduced as well. And this is one of the reasons we do regional anesthesia in the first place. The problem is, even though we have these enhanced recovery programs in place, they've been published, ASRA, ESRA, Prospect have all published enhanced recovery programs. If we actually look at people adhering to them, or institutions, hospitals, clinicians adhering to them, only 12 to 21% of people are actually using this. I'm not sure where they hide, because in my hospital, I would like to think it is much closer to 80%. But there is still a lot of pushback from managers, from surgeons, from just the system that people work in, and the compliance of a comprehensive enhanced recovery package, including regional anesthesia, is still there. This is an article from Narinder Narwal, a good friend of mine, and it just shows you how we've changed in our practice over a few decades. You know, many years ago, it was obviously just general anesthesia, then neuraxial blocks, then the sciatic femoral nerve blocks, which was in the 90s, and now we are concentrating just on the particular joint that we are interested in. And this can be local infiltration analgesia by the surgeon, femoral nerve blocks, or we'll talk about the ultra long-acting Esprel as well. Again, just a nice summary for you of what to do and how to select your different nerve block options. And I think this will vary depending on where you work, your setup, whether you have block rooms, whether you have patient orthopedic surgeons, because I don't think I know any orthopedic surgeon that will wait for a block to go in. So block rooms definitely do help with the efficiency of getting more and more patients done. But again, the emphasis here I would like to make, and I'll go into the individual bits of these as well, is that there is on the left-hand side an anterior aspect, which comes from the lumbar plexus, which you have to address. And from the posterior side, there's the sacral plexus, and you have to do something about the posterior side of the knee as well. And as long as you have some form, and you can pick almost what you like. So if you could have the femoral nerve block for the anterior and the surgical local infiltration for the posterior, or you can have the other way around. You can have the IPACK block for the posterior, but and the surgical infiltration for the anterior side. So don't forget that surgical infiltration is an acceptable and works well, but it does depend on the surgeon as well. Some surgeons are very meticulous and they know the anatomy, they know where those genicular nerves are, and I'll mention those in the future again. But others just squirt in, and I know exactly which surgeons I am going to do an IPACK block for which surgeons I'm going to do an adductor canal for, because I know that when they inject the LIA solution, they are not meticulous, they are not getting it in the right place. So know your surgeon, know your surgery, know your patient. Now you mentioned, let's just talk now. So I'm going to talk about the anterior aspect of the knee and maybe options here. And we all know that femoral nerve block was something that we did for a long time, and even femoral nerve catheters. But there was always this mobilization and the fall risk, which I've already spoken about. So we started moving further down the leg, and there was the introduction of a adductor canal block. And if you then compare some of the studies, you'll notice that you get similar analgesia, but then you get similar mobilization. So was it really a adductor canal block, or was the femoral nerve block not really affecting the mobilization? There was obviously a few more studies done about quadriceps weakness compared to adductor canal and femoral nerve blocks. And obviously the quadriceps weakness or strength was slightly better with the adductor canal block. And if you look at fall risks and things like that, so you can mention that people were comparing adductor canal and femoral catheters and blocks with each other. The problem is that we had mixed results, because in these particular studies, you will see that you get similar analgesia, but better mobilization with the adductor canal. And this was rather confusing, because with one adductor canal, you're getting similar mobilization. Then another study shows you that you get inferior analgesia with an adductor canal. So what was the problem? Oh, sorry, I just wanted to mention about whether you do a single shot block or a continuous peripheral nerve block. And this is not just adductor canal, this is all catheters for knee surgery. And they looked at, doesn't matter where you put the catheter, whether it's femoral, adductor canal, that you do get superior analgesia at all times for all catheter locations, and that you get a reduction in opioid-related side effects, which is obviously one of the things we want. Sorry, let's get back to the adductor canal and why there was this big discrepancy about where we did the block. And you can see on the picture on the left there that people were calling A, adductor canal, B, adductor canal, C, adductor canal. Obviously, that is almost a 15 to 20 centimeter area, all being called exactly the same thing. And this can't be right, because you will obviously get different nerves, different innervation, and different mobilization and quadriceps weakness, depending where you inject and what volume you inject. So this is why I think we had these initial mixed results, because everything was called a adductor canal. So basically anything below a femoral nerve block was called a adductor canal. But we'll go into a bit more detail. Thomas Benson and good friend of mine, Jens Borglum, they looked at actually redefining the adductor canal block again, because if you look at the red arrow on the left up there, you are almost still in the femoral triangle. The blue is what I would call the distal femoral triangle, and the green is possibly where the adductor canal is. So this vastoadductor membrane, which is the arrows in light blue on the ultrasound image, when you see that, that is the start, that is the roof of the start of the adductor canal. The red is obviously the artery. and the sartorius muscle is over that. So a big difference depending on where you are. So I think a lot of the studies, especially the initial studies, whether they were being called adductor canal blocks, were actually femoral triangle blocks or even distal femoral triangle blocks. And hopefully in the future, we are currently ESRA and ASRA. We are collaborating with each other to come up with block nomenclature so that we can actually compare studies that are actually comparable, because there's no point comparing a femoral triangle block with a true adductor canal block and hoping for the same results. And this is why we had those discrepancies in the initial results from these particular blocks. The point is, all of these things are actually still helping your patient. So actually, some regional anesthesia is better than no regional anesthesia. And that's what that's the main message. So this is why people are looking at a continuous proximal versus distal adductor canal blocks. And they looked at the, as I say, quadriceps weakness and at mobility. And you can notice that a continuous adductor canal block then can help you facilitate earlier discharge home and reduced opioid bed. Just let you know, there are other things that are in the pipeline that some people are using, and this is from Brian Aylfield again. Again, this is percutaneous peripheral nerve stimulators, and you can now place them. They are ultrasound guided, and they just adhere to the patient, and they stimulate the nerve, and that way providing analgesia, almost like a TENS machine that people use in obstetrics. But this is then peripheral nerve stimulation, and there's not much work out yet, but Brian Aylfield is working on that. So this is something for the future that potentially could help us as well. Another something for the future is also percutaneous probes, where you're looking at cryotherapy, cryoneurolysis. You freeze the peripheral nerves, and again, this is something that some people in the States are starting to use. It's not something that I use or that's available in my hospital, but I think that we are realizing that knee replacements are painful, and we need to do something to help with the pain. Now, this again is Jens Borglum's group, and they did what I would say a true adductor canal block. And they looked at the spread of the dye. They did this in Innsbruck with Professor Morrigal from Innsbruck Anatomy Department. And they injected dye into the true adductor canal, and there was distal spread to the genicular branches and the obturator branches at the back of the popliteal fossa. So if you inject distal enough in the true adductor canal, you will get spread of local anesthetic down to the posterior aspect of the knee. So this is a possibility. So you could do what I would say is a true adductor canal block and a femoral triangle block. So one is your posterior aspect of the knee, one is your anterior aspect of the knee. In another article, they were looking at the obturator nerve block, because the anterior, one of the branches of the obturator nerve obviously forms part of this posterior popliteal complex. And this is what people are now referring to, this conglomeration of nerves on the posterior side of the knee capsule. And this is the popliteal nerve plexus. I did not give it that name, but it seems to work because it's a combination of the tibial nerve, the posterior division of obturator, common peroneal, and possibly sciatic nerve as well. So difficult to block that with just one single nerve block. The genicular nerves. So the terminal branches of these nerves are the genicular nerves, and this is even a nice study just showing that we can use genicular nerves, and this is something that we are in my own hospital starting to use or starting to look at. A good friend of mine from Wales mentioned this for me, and he's a chronic pain specialist, and he's been injecting the genicular nerves for post-operative chronic pain for some time, but now we are only starting to use this for immediate or acute post-operative pain. So this is something to look at, and this is a picture that I stole from Jeff Gatson from Duke's Anesthesiology, and this just shows the innervation, the genicular nerve innervation, and he has a very good video on his website that shows you exactly how to inject the genicular nerves, and you obviously get the superior lateral, superior medial ones that you need to block, and the inferior medial one. Apparently very easy to do because you have a nice bony landmark. So with an ultrasound machine, you can do individual genicular nerve blocks. And this is just some ultrasound images to see where they are. I think if you do have a surgeon that is very meticulous about injecting around these genicular nerves, and he does that meticulously, then you might not need to do this yourself. And from Jeff Gadsden's talking to him recently, he's mentioned that now the surgeons don't, in his hospital, the surgeons don't do the infiltration of local anesthetic anymore. The anesthesiologists do it all. So they do a femoral triangle block, a distal femoral triangle block. Then they do an IPACK block, which I'll mention in a moment. And they do individual genicular nerve blocks. So it sounds like a lot of blocks, and this is why you do need the right system and maybe a block room preparation area where you can do this and perform these blocks. Otherwise, you might take too long before surgery is ready. I've mentioned the IPACK, so this is another a block that has been, I wouldn't say invented, but described and also been modified already. And again, this is for the posterior aspect of the knee capsule. It stands for infiltration between popliteal artery and capsule of knee. So just an acronym which explains exactly where it is. And it's not very difficult to do. I normally use a curvilinear probe. The important bit is that you just place the needle from medial, because you don't want to go lateral, because then you can actually block the common peroneal nerve and get foot drop. But from medial and then between the capsule of the knee and the popliteal artery, deposit local anesthetic. Try not to go into the capsule of the knee. Some of the orthopedic surgeons would get upset, thinking from an infection point of view, even though none of those particular complications has been described that I'm aware of. This is the ultrasound image going from the medial side, and you'll notice that the reason you go from the medial side is that on the bottom left lateral side is your common peroneal nerves. And then if we compare all of these things with the IPACK, with the adductor canal block, we realize that it is helping with postoperative analgesia. And everybody has been doing these blocks all of a sudden. So it seems to be the new fashion. I think before COVID, the adductor canal was the most fashionable thing. And I think during COVID, the IPACK block seems to be the most fashionable thing. So people are looking at this. But if you look at the efficacy of this as part of multimodal analgesia, it seems to be reducing the posterior knee pain only for 6 hours. So maybe not as long lasting as we'd like it to do. And very recently, I won't come to this one, same story really. This is the meta-analysis done by Eric Albrecht and Karim Albogdadli, looking at all of the IPACK studies after knee surgery. And you can see that unfortunately the results are not as advantageous as we thought. I must admit that our results seems to be better than what they suggest. I get the impression that our patients has benefit for longer than 6 hours, and I would continue to do the IPACK block with the adductor canal block for my patients. I know that a lot of hospitals are wanting to do day case total knee replacements, and the study recently came out saying that if there's an increased age, the BMI is too high, female, non-white race, hypertension, and multiple comorbidities, those are the patients that you should not select for day case knee replacement, which I think all makes common sense, nothing really new, but actually they've done a proper study to show these predictors. Part of this getting patients in and out of hospital and part of regional anesthesia is also multimodal perioperative pain control. And some people are using ketamine as well along, ketamine intravenously, not in their spinal. They use a spinal anesthetic, some ketamine, and then regional anesthesia. People are trying to add other things, and you can see Ellen Delbos's group. They tried to look at the effect of the addition of intravenous dexmedetomidine. Unfortunately, that did not enhance the analgesic duration. And again, Vincent Chan's group here looked at dexamethasone in the local infiltration for total knee arthroplasties, and that didn't seem to make a difference. We know that this is local infiltration, not perineurally. Whereas we know that dexamethasone intravenously can extend the duration of single nerve blocks. I just have to mention, for completeness sake, liposomal bupivacaine, which in theory seems like a fantastic idea, and you think that with LIA, with periarticular liposomal bupivacaine, that would actually be the answer, and we will get this really good analgesia for 72, 96 hours. Unfortunately, it does not live up to expectations, and this systemic review is showing that. And if you then look at the price connected to Esprel, again, I have no experience with this. It's not available in the UK, but from all the publications that I've seen, it's just not delivered as well. I know that it can be used for interscalene blocks and for other peripheral nerve blocks as well, but it has not actually delivered what was expected. Other things just to remember when we are talking about the complete package of total knee replacements is that we often forget about this transitional pain. So where you have the perioperative or intraoperative pain, and then you're going on to postoperative pain, there's a transitional pain area. And often our nerve blocks and the patient then going to outpatients falls into a gap. And this is where preemptive analgesia and a transitional pain service seems to be doing a lot of good work. And Toronto and quite a few other hospitals have now set up a particular multidisciplinary program looking at the transitional pain, because no point keeping the patient really, really comfortable for 48 or 72 hours in hospital, discharge them home, and then not do anything in particular. So you need to continue that good work that you have initiated in a hospital to reap the benefits in the long run. So a transitional pain service, again, is a multidisciplinary bit, so the actual surgeons need to be involved in it. And then the other bit, maybe a bit more relevant to the USA, is that you have a prescribing and a tapering protocol of opioids. If you just provide a patient with opioids for as long as they like and say, you carry on, you just take it whenever you like and for as long as you like, they might get addicted to it, as I've mentioned in my opening slides. So you need a tapering protocol and reducing the opioid dependency of your patients. ASRA has now given practice pathways for total knee arthroplasty, and so has Prospect, which is sponsored or part of ESRA. So I would advise you to look at these, and it really comes down to the things that I've mentioned already in this particular lecture. So it is an individualized protocol care. You have to look at your patients. You need to make sure that regional anesthesia is part of your multimodal analgesia. It is a multidisciplinary protocol, so make sure that your surgeon is on board, that he knows what blocks you're doing. And if he doesn't want to do the local infiltration properly, then you take over and you go do those genicular nerve blocks. You have to audit your results and then come back and refine, change things, audit them again, change things, audit them again. You can't just implement something and not actually see if there's any results. And I think our outcome criteria needs to change as well. You know, look at those dreams, aspirations that we have. Mortality and it's not an outcome, a relevant. It is a relevant outcome, but it's not a helpful outcome anymore. Patients have expectations, and they want to be, as I said, walk their dog, sleep without pain. And if we reach those outcome criteria, then we are doing the job. I've mentioned dreams a few times because I think this is the way that we can judge whether our regional anesthesia techniques are working well and whether we actually have an influence on the perioperative and post-operative part of the hospital. And if we are doing our job properly, we should be helping them. Just in summary, again, when you're looking at knee analgesia, obviously we're going to have a spinal anesthetic for the surgery, but for analgesia, you need a lumbar anterior approach, or you need a sacral posterior approach, and you cannot do one without the other. And I've given you a few options. It's very difficult to change things in a big institution in a hospital, but if you can change things that can make a big enough difference, then please carry on. Remember, there are preoperative, intraoperative, and postoperative parts, not just to this pathway, but also as part of our jobs and perioperative. You know, we're not just anesthesiologists anymore. I think we are sort of perioperative clinicians. So we need to look at patient education. And if I have a patient, a chronic pain patient coming in for a total knee replacement, then my analgesia plan will be completely different compared to a patient that is completely opioid naive. So identify those high-risk patients, use the appropriate regional anesthesia techniques. There's always a balance between mobility and pain relief. We know that. Use not just one aspect of multimodal analgesia, but all of it. Get a transitional pain team involved, and remember to taper the opioids post-operatively within those 3 months of surgery. Thank you very much for your time and attention. I will now stop sharing and give back to Nick.
So I think I will continue now. Thank you very much. Can you hear me, Morné?
Yes, I can.
Yes, okay. I think it's my part now, and we will discuss both presentations at the end of my presentation. First of all, I apologize for my pronunciation, but since I've been wearing braces for some time and I lisped something, sorry for that. This is my conflict of interest. I got honorary from different companies, but this will not influence my presentation of today. I think when we are offering nowadays regional blocks to our patients, we cannot no longer focus only on anesthesia or analgesia. You mentioned already, Morné, we also should focus on other criteria, for example, early mobilization, discharge, good joint function, return to normal life. And also the questions of cost is something what is important in our daily practice. And you also mentioned that when we apply regional anesthesia techniques, this should always be part of a multimodal analgesia concept. Every block stops working after hours, or if you have a catheter after some days, and then you need an additional analgesic concept, and you should always combine regional blocks with non-opioids. And this are the issues or the topics I'm going to talk during the next 30 or 40 minutes. You see the different kinds of surgery: shoulder, upper extremity, hip. You referred about knee and lower extremity, thoracic procedures and spine procedures. And you see in the next, you can see the so-called standard blocks. I listed these standard blocks based on what we have seen, what we see in the literature, what is the evidence, but also what is my personal experience. And the main part of my presentation will focus on alternatives. What are alternatives? What are new blocks? And do these new blocks have the potential to replace the so-called standard block in the future? So let's start with shoulder. I think we are all familiar with that the Interscalene Block is the gold standard. It can be used as an anesthetic or analgesic, and you can also use catheter. The only thing you have to remember, or the only side effect, is that you have a phrenic nerve palsy and the hemidiaphragmatic paralysis. This here is the standard procedure as we did it for a long time. An in-plane approach, you place the needle tip between the roots and then you inject local anesthetics, and this local anesthetic will block the phrenic nerve. A variation or a modification is when you advance your needle only not interfacially, you stay extrafacially in the close to the nerve roots, and then you inject only a small amount of local anesthetics, for example, 10 ml of local anesthetic, and then you will have a high chance not to block the phrenic nerve. And here there is a comparison between extrafacial and intrafacial from Eric Albrecht, and you can see that you can reduce the phrenic nerve paralysis from 41 to 15% when you stay with your needle extrafacial. In our department, we do not an in-plane approach. We always prefer an out-of-plane approach, because when you do an in-plane approach, you can hit or touch the long thoracic nerve or the dorsal scapular nerve, which runs in the middle scalene muscle. And when you advance your needle close lateral from the nerve roots, you avoid any kind of touching the long thoracic and dorsal scapular nerve. And we inject around 10 ml of local anesthetic. And with this technique, you also have a high chance not to block the phrenic nerve. So for me, a modification of the interscalene block, if you use a low volume and if you stay extrafacial, then you have a better preservation of the phrenic nerve. But we know that the main nerves which innervates the shoulder are the axillary and the subscapular nerves, C5, C6, and we can also block these nerves. For the subscapular nerve, we can block this nerve posteriorly and anteriorly. And if you use a combination of suprascapular and axillary nerve, and you compare this with an interscalene block, you can see you will find the same amount of analgesia, but you have less dyspnea and discomfort compared to the interscalene block. So a combination of these two blocks can be an alternative, but this is more or less an analgesic block. Maybe there are some case reports that you can use these blocks for an endoscopic procedure, but what you will never have a phrenic nerve palsy, and catheter can be used, but from my experience, only for the suprascapular nerve. You can also use a suprascapular block. With these blocks, this can be also used for shoulder surgery. And when you compare the vital capacity between the interscalene, supraclavicular, and suprascapular nerves, you can see the best preservation can be found with the suprascapular nerve. But when you compare interscalene and supraclavicular, with the supraclavicular, the preservation is better, indicating that you have a better chance not to block the phrenic nerve with a supraclavicular block. So the supraclavicular block is another alternative, but I'm not sure if this is sufficient for anesthetic, maybe sufficient for endoscopic procedures, but you can, and also the use of catheter is limited by the because the proximity of the injection point is close to the incision, surgical incision. So for me, now in the future, the modification of the interscalene block will be the gold standard if you use a low volume and if you stay extrafacial. So we move now to the upper limb. I also think you agree that the axillary block is the standard block for the upper limb block. You can do elbow surgery and hand surgeries with this block. It's a very safe block. You will not find serious complications. The only thing you have to remember is this is a vessel-rich area and you have to do, for example, 4 blocks. And then you have a higher chance that you will find a systemic intoxication. This block can be used for anesthetic and analgesia. And at least you have to do 2 blocks. You have to block the muscle-cutaneous nerve, and you can inject around the axillary artery. But I personally prefer to do 4 injections to block the radial, the median, and the ulnar nerve. Alternatives are infraclavicular blocks, and we have the well-known lateral infraclavicular or the coracoid block by Klastedt, published in 2005. A modification from this is the so-called retroclavicular or the RAPTIR block. With this block, you should have a better view on the needle because you advance the needle perpendicular. This is indeed the case. Sometimes is the target very deep, and you have, when you use the lateral infraclavicular sagittal block, you have a steep angle, and when you do this block, you should always use echogenic needles. But one thing you have to remember when you do the retroclavicular block, in the beginning, the needle is covered by the clavicle, and so that means you have to advance the needle blindly. Another option is the costoclavicular block, published by Kamaka 2015. And if you compare the coracoid with the retroclavicular approach, you can see a better needle visualization at the end, and you have a reduced performance time. And when you compare the lateral sagittal with the costoclavicular approach, the costoclavicular approach showed a faster onset of the sensory blockade. And this is a publication demonstrating that the costoclavicular approach can also be used for shoulder arthroscopy. And when you compare this block with an interscalene block, you can see the same pain scores with both, but when you look at the number of hemodiaphragmatic paralysis, you can see with the costoclavicular block, you find nothing compared to 100% when you do an interscalene block. But you can see the interscalene block was done with 20 ml of levobubivarin, which means for me a high dosage. So a comparison of these three infraclavicular approaches, you can see all of them can use for anesthesia and for analgesia. You can use catheters, and the risk of pneumothorax is indeed apparent, but when you are experienced with ultrasound, you should minimize the risk of pneumothorax. And this is again a picture which shows you why the costoclavicular block can be used for shoulder surgery, because it's a very proximal block of the cords or the divisions, very close to the clavicle. And if you do a classical Lisp or retroclavicular block, you will block the cords more distally, and that's why this is not sufficient for shoulder surgery. Supraclavicular blocks can also be used for upper limb surgeries, and when you compare with infraclavicular, you can see in this study that the performance time and onset time was shorter with the supraclavicular block. And when you compare catheters, infraclavicular with supraclavicular catheters, you have a superior analgesia with infraclavicular catheters. And this is also our practice. When we use when we need a continuous block for the upper limb, then we always use an infraclavicular approach. So supraclavicular is also possible for upper limbs and suitable for shoulders. And if I have to judge what is the future, so you see, this is my personal experience and my personal view. I would say for me, an infraclavicular block could be the future for the upper limb block. But if we have more data regarding the costoclavicular block, probably this is also an option for upper limb blocks. We move now to hip procedures, hip fracture, hip arthroplasty, or hip arthroscopies. And I think you know that since we know that the hip procedures are not as painful as the shoulder, knee, or ankle procedures, I think in many institutions, hip procedures, there are no kind of regional anesthesias provided. But in our department, we do nearly every kind of hip procedure. We use any kind of blocks. And if you look at the literature, I think the most common block worldwide and the so-called standard is probably the femoral block and the lumbar plexus block or psoas block. The psoas or lumbar plexus block is for me the most complete block for hips because in contrast to femoral, you block not only the femoral but also the obturator block, which is also necessary for the anterior part of the hip joint, and if you use a lumbar plexus block in combination with a proximal sciatic block, you can do also the operations. You can use this as an anesthetic. But you have to keep in mind the lumbar plexus block is a block near to the spinal cord. Therefore, you have to follow the same regulations or regarding anticoagulation that we also use for neuroaxial blockades. And the lumbar plexus block is, I think, a difficult block and an advanced block. Instead of the fact that we know that the axial Sauter approach, the Shamrock approach with ultrasound, made this block more easier. But ambulation is impaired with femoral and lumbar plexus block. What are alternatives for hips procedures? This is the fascia iliaca compartment block. Earlier we did it infrainguinal. Now we only use the suprainguinal approach. And with the suprainguinal approach, we constantly can block not only the femoral nerve, but also the lateral femoral cutaneous nerve. And there are many data showing that with the suprainguinal fascia iliaca block, you can reduce the amount of opioids postoperatively. But there are also some conflicting data. You can see here, I will show you this publication comparing a fascia iliaca, suprainguinal fascia iliaca compartment block with no block, but in both groups, they injected 10 ml of a long-lasting local anesthetic into the hip joint, and therefore, this is my explanation, therefore they didn't find differences in both groups. In our department, we would never inject local anesthetics into joints, except you have an arthroplasty, because local anesthetics are chondrotoxic. So for me, the fascia iliaca block is an alternative for hips because up to now there are no reported nerve injuries with the fascia iliaca blocks. Catheter can be used, but not for hips because the injection point is close to the surgical incision. What are other options? This is the transmuscular quadratus lumborum block, or the lumbar erectospinal plane block, or the PENG block. The transmuscular approach is indeed, first described by Jens Borglum, is indeed a block which covers the lumbar nerve roots, but only the anterior block will do this, not the lateral or the posterior quadratus lumborum block. And therefore, we have case reports and some case theories showing that the anterior or transmuscular quadratus lumborum block is effective in hip procedures, but we are lacking randomized comparative studies. But it's an option, and the good thing is that you do the block far away from the surgical incision. Therefore, you can also use catheters for this. The next one is the lumbar erectospinal plane block. I think everybody knows there's a huge ongoing discussion about the working mechanism of erectospinal plane block. Is this maybe a systemic effect? Maybe it's the ventral rami of the spinal nerves are blocked and so on. But from my experience, I can say if we do lumbar plexus blocks, in many cases, not consistently, but in very many cases, you can have an analgesic effect after hip surgeries. So there are also some case reports in the literature and some case theories showing that the lumbar erectospinal plane block is effective in these kind of surgeries. As you see here, a comparison between lumbar erectospinal plane block and quadratus lumborum, and for both blocks were efficient in pain therapy after this kind of procedure. So it's an option, but we have to wait until we have more data if this is a really promising block or not. And finally, we have the pericapsular nerve group block, or PENG block, published 2018. And with this block, in the first publication, there was no quadriceps weakness. It was used for hip fractures. And Why this is a so promising block is because you block only the distal joint fibers of the femoral and the obturator nerves, and therefore you will provide an excellent analgesia for the hip, but without any kind of motor weakness. Up to now, we have a growing, increasing number of publications with PENG in hip procedures for hip surgery, hip fracture, also for hip arthroscopy. And recently, in May this year, there's published a randomized comparative study comparing PENG block with femoral nerve block, and the authors could show for hip fracture, and the authors could show that the immediate short-term analgesia was better with PENG, and also the quadriceps strength was better preserved with the PENG block, which is not surprisingly. So PENG block maybe it's a real good option for hip fractures or hip procedures, but we have to wait until we have more data. Catheters are possible, but again, this block is made very close to the surgical incision, and I don't know if this is an option for hip procedures. Real complications are not reported so far. And my final judgment, if I would have to evaluate what are the blocks for the futures for hips, maybe fascia iliaca and maybe PENG blocks are candidates for this. Now and you can see here, by the way, Morné showed you also some results. This from the prospect. This is an expert group giving recommendations for anesthesia and analgesia for different kinds of surgeries. And you can see the recommendations for hip arthroplasty. It's an old one from 2010. And you can see here, it's still recommended a femoral nerve block and catheter or a posterior lumbar plexus block and even the epidural catheter. I think this is a little bit old-fashioned, and a new recommendation is on the way and in the pipeline, and these new recommendations will absolutely include the newer blocks. So now we move down to lower leg, ankle, and foot, and the kind of block we use depends first from the surgery. If we do a lower leg, ankle, or foot surgery, it also depends where we place our tourniquet at the thigh level, leg or ankle level, and it is always different from surgeon to surgeon. Some of the surgeons wants to have the tourniquet far away from the the operation site. Some accept when the tourniquet is closed there, but this will influence also the kind of blocks. Here, this is my personal view. For me, the distal sciatic block in combination or without a saphenous block is the gold standard for a lower leg, ankle, and foot. It's an anesthetic block which can be used for anesthetic and analgesia. Real complications are rare. You can use catheters, but this is the bad news. If you use it, the ambulation is really impaired. How should we do it? You can do it at the level of the popliteal crease, or you can do it a little bit more distally. In our department, we usually do it at the level of the popliteal crease, where you have already the bifurcation, and you can see here very nicely the so-called donut sign. When you do it at the level of the bifurcation, we do it, it's always a subfacial block. We inject the local anesthetic below the common facial sheath of both nerves, but it is not an intraneural injection because we do not inject the local anesthetic into the peroneal and tibial nerve. But by doing this technique, you will have the fastest onset of block compared to when you place the local anesthetic extrafacial. How should we do it, in plane or out of plane? It depends on how you can see the location of the both nerves in the ultrasound. When the nerves are located in parallel, which is in 70 to 90% of cases, then I always prefer an out-of-plane approach. When the nerves are located vertically, then I prefer an in-plane approach to go in between both nerves. When we use catheters, should we advance the catheter in plane or out of plane? You can do it by this way or that way, but there's a publication showing when you advance the catheter out of plane along with the nerves, then you have a lower displacement rate compared to the out-of-plane approach. So we prefer in our department also the out-of-plane advantage. Is this block of the saphenous nerve necessary when you do major ankle blocks? In this publication, it could be shown that the additional block of the saphenous nerve reduced the or improved the pain perception after the operation. A saphenous nerve block can be done at different levels. At the level of the adductor canal, we can do it above the knee, or we can do it separately block just below the knee. Beside the distal sciatic block, we can also do different ankle blocks. There are 5 different ankle blocks, which must not be done all together, but more or less you have to do 2 or 3 depending on the kind of surgery. But I think ankle blocks are, for minor surgery, very good alternatives. The disadvantage is you have to do several punctures and you cannot use catheters, but I think this is not an option because ankle blocks or minor surgery are mainly ambulatory procedures, and the patient can, and this is a good thing, the good news, patients can work home when they had ankle blocks. So to summarize, for lower leg or major ankle block, I think the distal sciatic block was and will be in the future the gold standard, but for minor, for forefoot or midfoot surgeries, ankle blocks are the gold standard. So here, this was Prospect recommended for hallux valgus repair surgery. They recommended the ankle block as first option. And another thing is important. Is the saphenous nerve block important for hallux valgus repair? You can see only in 3% the saphenous nerve is necessary, because this is not normally, you don't need to do a saphenous nerve block for hallux valgus repair. Now we move away from the extremities. We move to the thoracic surgeries. What is the gold standard? The gold standard, I think, is the thoracic epidural and the perivertebral block. You know, both are anesthetic analgesic blocks. You have a visceral analgesia. You can provide a visceral analgesia with this, but with the perivertebral, you have a better side effect profile regarding ambulation, regarding bladder function. But both are blocks. You have to follow the recommendations for anticoagulation that you follow for new axial blockades. And this is the limitations, because many of the older patients are anticoagulated or have problems with the anticoagulation. Catheter can be used. And these both blocks are also the first line procedures, also recommended by the Prospect group here, thoracic epidural and perivertebral group. But we have other options. We have, for example, a thoracic erectospinal plane block, which can be used, and it's a very easy block and a very safe block. And there are case reports, again, or case theories with the use of the thoracic erectospinal plane block, successful use in, and you can see here a comparison of erectospinal plane block with thoracic perivertebral block for video-assisted procedures, and you could find the same kind of analgesia when you compare both of these blocks. So I think the thoracic erectospinal plane block is an analgesic block only, but it's a real option for minor thoracic procedures. Another option is the serratus anterior plane block. This can be it's also a very safe and simple block in my eyes. And there are also some reports when this block was mainly used for thoracoscopic procedures. And also you can see this is also, for me, in my eyes, an option when we have better data, when we have real comparative studies. Then I think this also is an option for minor thoracic procedures. But recently there was a comparison between erectospinal plane block and serratus anterior plane block for minimally invasive thoracic procedures, as you could find, and they found, the authors, that the ESP was a little bit better regarding analgesia, providing analgesia in these patients. So for me, for major thoracic surgeries now, and I think also in the future for me, these two candidates, the thoracic epidural and the perivertebral, are the best candidates. But for minor, minimal invasive thoracic procedures, probably in the future, we have with the thoracic ESP and the SAP, we have very, very good candidates. Finally, we move to spine procedures. And here we also have minor and major procedures. And you can see here the recommendation from the prospect group for minor procedures, for laminectomy. Laminectomy, this is the bread and butter business. And you can see here, I show you what they do not recommend. For these minor procedures, they do not recommend any kind of regional procedures, no epidurals and no paravertebral. This is not necessary. If you do a good multimodal analgesia, if you have a good multimodal anesthesia plan, then you will cover the pain resulting from these minor procedures. But we also have complex spine procedures, mainly the body fusions, the intervertebral replacements. Also, we have the scoliosis operations, and I think more in most anesthesia areas. There will be no block provided, but in our department and in some departments, and there is also good literature, literature data, we always use in these major complex spine procedures an epidural catheter. But this epidural catheter is placed at the end of the procedure by the surgeons. You need a cooperative surgeon or a surgeon who appreciate the value of these techniques, and then he will place, you can see here in the pictures, he can place before, at the end, he placed this epidural catheter. And you can see here, I took behind anticoagulation a question remark, because I'm not sure if we need the same recommendations when this catheter place is under direct vision by the surgeon, if we need the same restrictions that we use when we do when we place this catheter by landmarks. But we also have other candidates from complex spine surgeries, the so-called paraspinal blocks. These are the thoracolumbar interfacial plane blocks, or these are the retrolaminar block, or again the ESP block, or the perivertebral block. The perivertebral block is used in our department when we do transthoracic endoscopic procedures. For these procedures, we place a perivertebral block or catheter before we start the operation. There are not so many data in literature on this, but our personal experience is that we can provide a good analgesia in these patients. Next one is the retrolaminar block, first published 2005 by a German surgeon. And you can see here, this is a very safe block because the end point of your needle is the lamina. It means a bony structure. You also can advance a catheter. And there are some very few publications on using the retrolaminar block for laminar procedures, and I think it's too early to recommend any kind of retrolaminar block, but this block exists, and we have to wait if we have in the future randomized control study and if there will be some evidence for this block. Next one is the thoracolumbar interfacial plane block. It's a little bit a modification of an erector spinal plane block. Also here, even there exists one randomized comparative study with the thoracolumbar interfacial plane block with systemic opioids, and you can see here with this block you could find a significant, you could reduce the opioid requirement post-operative during the first 48 hours compared to systemic opioids. But again, we have too little data up to now to say that this is a block, this block can be recommended for these kind of procedures. The ESP block, you know, the ESP block can nearly use for every kind of operation in the whole body, and there are increasing data using this block for posterior spine surgery, lumbosacral spine surgery, anterior lumbar spine surgery. And I think this is an interesting block, but for this kind of procedures, you have to do this block bilaterally, and probably you have a problem because it's a high volume block. You have to remember you use high volumes of local anesthetic. Probably last will be a problem in these blocks. So for me now and in the future, for me for complex spine surgeries, if you trying to use a regional block, I think the epidural catheter placed under direct vision by the surgeon at the end, this is an option. And in our department, when we do a complex scoliosis operations from the high thoracic level area to the lower lumbar area, we use 2 catheters. And the epidural catheter are also recommended by the prospect experts. This is recent published pain management after complex spine surgery, and also they advise the lumbar epidurals. So I come to my last slide, and I will finish with the recommendation. What are the future trends and what are problems? What are the blocks in the future that we use? Will they replace the standard blocks? And you can see, I think for shoulder, a modified interscalene block is now, and for me in the future, the block of choice. For upper extremity, I think supra or infraclavicular, in our department, mainly the infraclavicular block is a good option. For hip, the fascia iliaca and PENG blocks. For knee, you have heard the excellent presentation from Morne, the LIA, IPACK, and distal sciatic blocks, which do not interfere with the motor function. For lower extremity blocks, you see for major, also in the future, the distal sciatic block is for me the first option. For minor, I think these are the ankle blocks, and for thoracic procedures, for major procedures, I think there's nothing else better than the thoracic epidural or the paravertebral block. And for minor procedures, probably this is the future for ESP on serratus anterior plane block. And for spine, for complex spine surgery, the best option to my knowledge is the epidural catheter. And now I'm at the end, and thank you for your attention, and I'm waiting for questions. Thank you very much.
Okay. Thank you very much, Professor Kessler. Very insightful lecture. And I assume that we can skip to the Q&A section. I noticed that Morné have already answered several questions in the Q&A section. So maybe we can pick some of the new questions here due to the time limit. Please, Kessler.
There's one from Jude Ramos about, does the ESP block cover the pleural pain by a chest drain? And I think in my experience, an ESP block is very variable, and it also depends on where the chest drain is, obviously. Sometimes I do exactly the same ESP block on the one side and on the other, and sometimes it's really, really successful, and other times it's just moderately successful. So I think it is, in theory, it should cover the pain, but I think it's often just an analgesia block and not an anesthesia block. I don't know if you agree, Paul.
Yes, absolutely. But my experience is this for chest drains, for chest tubes, usually it works very well, but not. It's only you will only always cover the parietal pain, the truncal pain, but not the visceral pain. And the chest tube is for me a minor painful procedure. The only thing is that during breathing, it's very painful, yes. But the ESP is a candidate in my eyes, which can be used, especially when you remember that it's a very safe block without any serious complications.
Yeah. And the next question is about the local anesthetic migrating to the subarachnoid space. I think in my opinion, that does not happen into the subarachnoid space. I think you can have local anesthetic migrating from a retrolaminar or TLIP block to the sympathetic chain. And I think that is a good thing, because I think that helps with the analgesia. There has been some evidence to suggest that people just doing sympathetic chain blocks gets good analgesia from that. But I cannot see how it can get to the subarachnoid space.
The only way would be that you have a huge amount of local anesthetics in the intervertebral foramina, and then the local anesthetics could go into the intrathecal space. But I have no data on this, and there exists no data showing this. The next one, where we deposit the local anesthetic in the PENG block, I think it's also a block which will not provide 100% consistent effect. Sometimes it works very well, sometimes not. But the recommendations of of PENG, who is first described this block, is that you have to place the local anesthetic beyond the psoas block, the tendon of the psoas block. You have to see when you inject that the tendon of the psoas block and the psoas block is lifted up, and you have to see that the local anesthetic is flowing medially from this tendon. Then you will have a well-working block.
Yes, I think the innovation of the hip joint shows that most of the motor component comes from the posterior aspect, and a lot of the sensory component comes from the anterior aspect. And this is why the PENG block gives you good analgesia without affecting your motor block. So I think that's the theory, and this is why those diagrams of Philip PENG is really helpful.
Yes, indeed. I have a question to you, Morné. Are you using for major knee surgeries catheters or not, if you have a simple knee replacement in a normal patient? Not an opioid-dependent patient.
In my hospital, in the current setup, no, we do not use catheters. But if I was having to have my knee replaced, I would like to have a femoral triangle catheter. So we're not using it, at the moment. We are sometimes our patients are still using LEA catheters. They're using intra-articular catheters for knee replacements, and we run an infusion of 0.2% ropivacaine at 5 mils an hour intra-articular. After, obviously, I perform an adductor canal block, and the surgeon does some LEA with the rest of the local anesthetic, and then we do an infusion of ropivacaine 0.2%. But personally, I would like to maybe take that infusion and do an adductor canal, or maybe a bit more proximal, what I would call a distal femoral triangle catheter.
Are you doing these procedures as day case procedures, or are the patients staying for a few days in the hospital?
The patients are normally staying 2 nights, occasionally 1 night. But we're not doing day cases yet, but we are starting to work on a protocol for day case surgery. But unfortunately, with the pandemic, the COVID pandemic, all our plans and our scheduling has been messed about. So we'll when we're back to normal, we'll start again.
Okay, I see. There's a question. Yes. Okay.
No, I just think, I think if you do, are you going to do knee replacements as day case surgery, you do need a very motivated patient. I've showed on my slides some of the selection criteria that's required, and also you must have a very robust analgesia plan, because knees are definitely painful.
Yes, absolutely. There's a question I don't understand exactly. Is there such an all-purpose hybrid block of the shoulder arthroplasty? I don't know what the
all-purpose hybrid block for the shoulder arthroplasty. Well, I think the all-purpose block for the shoulder arthroplasty is interscalene, and I think that is the block that we use most of the time. And I agree with you, Paul, that instead of the 20 mils, I now use 8 to 10 mils of 0.75 for ropivacaine for my shoulder replacements. So I do a posterior approach. I sometimes go a little bit lower, so you get mostly the superior trunk, which is C5 and C6. I use normally about 7 mils in that area. I also add a little bit of local anesthetic to the supraclavicular nerves. And occasionally I do a PEX2 block because it just provides a bit of analgesia when they go into the glenoid process. So for my shoulder arthroplasties, I would do a low volume posterior interscalene block, a low volume supraclavicular nerve block, and a PEX2 10 mils of diluted. So, and
yes,
that
exactly.
Really well.
Yes, yes. Sometimes we also combine an interscalene block with an superficial cervical plexus block, which will cover also the proximal area of the shoulder. Yes. And one comment to the interscalene block. I think it's one of the most proximal blocks we do at the level of the roots, and therefore we have the highest rate of transient neurological complications that you should keep in mind. It is can be a very complicated block with high complication rate, and even if you use catheters, we know the very rare, but we have some publications showing that the tip of the catheter, when you advance the catheter too far, that the tip of the catheter is in the epidural or even intrathecal space.
Okay. Another question was about the combination of subsartorial, a dual subsartorial in knee surgery. So yes, this was actually described by Jens Borglum. I think he called it the speedy block, where he did a femoral triangle block, a distal femoral triangle block, and then continued to do a adductor canal block, which then covered the anterior and posterior block. So that he called the speedy SPED block. So I think it's single point of injection, dual block, I think was what it was called.
Yes.
And somebody was asking about the femoral triangle, and my point about the femoral triangle is if you just look at the anatomy of the femoral triangle, then you're looking at the adductor muscles, and where the sartorius muscles cross each other, that will be the distal part of the femoral triangle, and the inguinal ligament will be the base of the triangle. My point is it's a large area. It's up to 10 to 15 centimeters long. And this is why the femoral triangle, I think we should divide into a distal or proximal point, because again, I think if you inject in different parts of that triangle, you will get different effects and different mobility and different analgesia. So for those people who don't know where the femoral triangle is, just look it up, and it's just the most distal part of it.
Yes, there's another question. Can PENG block relieve the pain in chronic pain setting? I don't know if there are case reports or something else, but I think absolutely, if you do a block, you will find a pain relief, and you can even place a catheter, so you have a pain relief as long as the catheter in the patient. But if you have a long-lasting pain relief of the chronic pain, I don't know if we have data on this up to now.
No, I don't know any data of that, but I can imagine that people would use the PENG block to establish where the chronic pain is where it originates from.
Yes.
The other thing was about adjuvant. Do I use adjuvant? So the only adjuvant that I use is intravenous dexamethasone. I think I would use perineural dexamethasone, but in the UK, we do not have preservative-free, and also it's not licensed to be used perineurally. It's interesting because, especially with nerve blocks, I'm not so sure about fascial plane blocks, but nerve blocks, you still increasing your duration of action by 1/3 by using intravenous dexamethasone. I normally use somewhere between 6 to 8 milligrams intravenously. If I was going to use dexamethasone Perineurally, I think it's important not to then use 6 milligrams in 10 mils of local anesthetic. I think that dose is too high perineurally. I would dilute and use 1 milligram of dexamethasone per 10 mils of local anesthetic used. I don't think you need such a high concentration of dexamethasone perineurally, but we seem to get the same effect whether we use it intravenously or perineurally. So at the moment, I'm sticking to intravenous dexamethasone.
There's another question. Do you use for column fusions infusions of lidocaine? In major spine surgeries, when we ask before we start, we ask this if the surgeon is willing to place a catheter. If he is not willing, we usually, especially in chronic pain patients or in opioid-dependent patients, we use lidocaine, or we also use a ketamine infusion for the operation. But only in special populations, or if you don't use, if the surgeon is not placing at the end an epidural catheter. Do you recommend, do you mix local anesthetics? Will you answer this question?
The one, experts, what do I recommend for needle vision? Is that the one? I was just saying that first I would say practice. I think it does take a little bit of time. The needle does not automatically jump into the beam of the ultrasound. So it does take a little bit of practice. I find that it is very easy, just with half an hour, 20 minutes, if you use a very small, low simulator, just a gel or something where you can practice your needling skills. That helps a lot. To try and practice while you're doing a block is very difficult. Getting the hand-eye coordination correct is very important. And this is why Professor Kessler's needle, cadaver needling courses is essential, and we still demand that people do needling cadaver courses before they do the EDRA examination. Otherwise, the echogenic needles do help, absolutely. A better ultrasound machine absolutely helps. So get the right settings. I often walk into an anesthetic room or procedure room, and the wrong settings is placed, and people cannot see because they don't know the basic setup of a ultrasound machine for the block. So make sure you have the right settings, the right needle. And then there is a few small maneuvers. Remember to try and get the needle at 90 degrees to, so if the beam is coming down, you want to come at 90 degrees to the ultrasound beam. Most of the limbs, the neck, the shoulder, the arms, the legs are round. So a big mistake people make is placing the needle right next to the probe, and then often it's a very steep angle. If you place the needle further away, then you can actually come in at a more parallel bit. Now, this is our practice in the UK and often in the US and Canada, but I know that the Germans and the French prefer an out-of-plane technique, and that maybe Professor Kessler can talk about why they prefer out-of-plane compared to the UK preferring in-plane.
Not for all blocks, but for some blocks, as I showed you for the interscalene block, we prefer the out-of-plane, and also very often for the distal sciatic block, we prefer the out-of-plane approach. I know there was some publication showing that the pain perception when you advance the needle is better when you do an out-of-plane approach, because for every out-of-plane approach, usually the distance from skin to the target is smaller compared to an in-plane approach. If you advance the needle in-plane, there's a longer way from the skin to the target, but usually you do in local anesthetic, so this is not, I think, an issue. I prefer, especially also for some deeper blocks, it's difficult to explain. I do an out-of-plane approach, and I advance the needle just very close to the probe, and then I advance the needle. And if you are very steep, in the direction of the ultrasound beam, then you can see, even if you do an out-of-plane approach, you can see the needle for 2 or 3 centimeters when you advance the needle. And nowadays we have needle tip tracking systems. When you can use this kind of needle tip tracking system, they facilitate to see where the needle tip is, even if you do an out-of-plane approach. Another question, a mix of local anesthetics to accelerate the latency. I think you have to keep in mind, if you mix local anesthetics, you dilute the local anesthetics, and probably I don't know if this is beneficial for the block, for the duration, and for the onset of the block. We usually do not mix local anesthetics. You should have time. Yes.
No, I agree completely. I don't recommend mixing local anesthetics. Often people think I'll mix 2% of lignocaine with 0.5 bupivacaine and get the best of both worlds. The problem is, I think you dilute it and you get the worst of both worlds. So you get a diluted long-acting and a diluted short-acting. The short-acting often still works and the block gets established, but it's not recommended. I think there are drugs now. If you look at all the different long-acting local anesthetics that are available, there are some of them that is really fast in onset, especially if you use the higher concentrations like 0.75 or 1% ropivacaine, like I use for my awake shoulder surgery, or you can use 0.75 levo. But you get a reasonably quick onset of that time, so you don't need to mix that with lignocaine. When I do hand trauma, I use an auxiliary nerve block or an infraclavicular block with a short-acting local anesthetic. I think in the future, this is where lignocaine, prilocaine, or 2% chloroprocaine will come in handy, depending on how long you want the block to last. This is a good block which covers the tourniquet and then the basis for your surgical anesthesia. But that will obviously wear off after a few hours, and then you need analgesia block. So I do a differential block. I do a short-acting proximal nerve block, and then I do a distal analgesia block at the elbow, which means that your block success is 100% because you are doing your rescue block before you actually need a rescue block. And the patient satisfaction has definitely increased because of that. So after 2 hours, they can move their arm, but they don't have the pain when the short-acting block wears off. Does that answer the question?
Next questions regarding the for shoulder surgery, should we combine a posterior cord block with a superior trunk block? And is this beneficial? I've never done this. Usually I do a superior trunk block and this works very well. And again, I would recommend, because it's a very sensitive area, you are at the level of the roots, you should not do too many maneuvers with the needle. You should look when you have found the correct place, then you should inject your local anesthetic and you should not replace your needle. Otherwise, there is a higher chance that you will touch the nerves, and this is not a good procedure for the nerves.
So what I do in that case, as you said, Paul, is often, as you mentioned in your lecture, people are comparing suprascapular nerve blocks and axillary nerve blocks, whether this is just as efficient as an interscalene block. In my opinion, the problem with those studies is that they are doing these blocks far too distally. They often do the suprascapular block in the suprascapular notch, and they do the axillary nerve block on the posterior aspect of the humerus, which is very distal. And this is why I would rather recommend that if you are trying to do something truly phrenic sparing, that you do a more anterior suprascapular nerve block. So from the superior trunk, C5 nerve root will split into 3 different nerves, and the most lateral, most superficial nerve will be the suprascapular nerve, which will move posterior underneath the omohyoid muscle. And there it is very easy to block the suprascapular nerve anteriorly with 3 to 5 mils of local anesthetic. And that covers the suprascapular, but the axillary nerve innervates the shoulder about 30%. And this is why I think this Fatapanel, no, I'm not pronouncing your name correctly, Fatanapol, is asking, should he do a posterior cord? So yes, I think if you cannot do the axillary nerve block anteriorly, then a posterior cord block can help, because the axillary nerve will come from the posterior cord. So in summary, as Professor Kessler says, a superior trunk block on its own is sufficient. But if you do an anterior suprascapular nerve block, then you still need the axillary nerve, and you can either do an anterior axillary nerve block, or you can do a posterior cord block infraclavicular. And with those techniques, I think you will get better analgesia, and you will get no phrenic nerve involvement. But these studies have not been done yet. These are just my own practice.
Next question here. Would you recommend stimulation in order to avoid neural injection? I think pure stimulation we have never done for many years. What we are doing is sometimes we combine ultrasound with stimulation, especially for the proximal sciatic blocks or for the lumbar plexus blocks. It's strongly recommended to use a combination of ultrasound and stimulation, because the visualization in these deep blocks is really impaired, especially in obese and older patients. And you should never do this block except of children and kids without nerve stimulation. But normally, usually we do the blocks only with only ultrasound guided.
Okay.
Benefits
So,
of
sorry guys, I noticed that today's attendees are very active. So our Q&A section is actually overloaded right now. I assume that we can have the one last questions.
Okay, let's see.
You can choose one, Morné.
I think we've answered most of them anyway. Benefits of nerve stimulation, role in success, no. The portable, I think when talking about the portable, is the portable wireless probe, can you do regional nerve blocks? I think, we know that ultrasound technology is improving all the time, and some machines will have portable wireless probes, and some don't. And it really depends on how much money you want to spend for good image quality. Often my problem is, if you do have portable wireless probes, they get lost. So if they are not attached to the probe, they get lost, and that renders the machine useless. So I actually quite like a wired probe that's attached to the machine, and with the improving ultrasound technology, the images are becoming clearer and clearer, and we are blocking smaller and smaller nerves. But you can block, with a wireless probe, the bigger nerves and so on. But a nice high frequency linear probe, and you can do most blocks with that.
Absolutely. I think the image quality is not comparable with the wireless compared to the big machines. And to my knowledge, there are nearly no data or no studies using these wireless portable probes. There are only feasibility studies showing that, as you mentioned, that these work very well for the bigger nerves, but not for the smaller nerves. And nowadays we want to have good image quality, and which is necessary for doing high sophisticated blocks. And I think at that time these portable wireless probes do not fulfill these criteria.
Yes, and I'm sure Wisonic has the probes and the machines to give you a high frequency, high image quality images, and I'm sure I looked at their website early on in the day, and there are different machines for different applications. So I think it is important when you purchase these machines that you purchase them for the correct use. Often I see people using obstetric and gynecology ultrasound machines, and they want to do peripheral nerve blocks. That doesn't always work. You need the right programming. Sometimes a machine can have dual purpose, where you can do FATE and fast scanning and still peripheral nerve blocks. So have a look at what your requirements are. I think for peripheral regional anesthesia, you need a high frequency and a good image quality.
Yes, indeed. Thank you, Morné, and thank you for your kind recommendation for ViewSonic. Indeed, ViewSonic is very focused on the professional and the specialty area, including like the regional anesthesia applications. We have very close cooperation with Professor Kessler as well to develop the application specialty in regional anesthesia. And yeah, I also noticed a very interesting question in the chat box that what's your favorite ultrasound machine? It might be a little bit sensitive today, but yeah, from my side, it's always ViewSonic. And we are very happy to have two experts with us today. In behalf of ViewSonic, I really have to thank you for your time sharing and your knowledge in our Dandelion College. Thank you, Professor Kessler, and thank you, Dr. Wolmarans. And
Thank you.
Yes, actually, for the audiences, our next webinar with Professor Kessler will be on the 27th of May with an Italian expert, Andrea Tognu, right? So please stay tuned with us and see you next time. Thank you all. Thank you. Bye-bye.
Bye-bye.
Excellent. Thank you. Bye-bye.
Thank you.